Good afternoon, Professor Jobs. Tell us a little bit about your position.
So I'm currently professor of ophthalmology and professor of medicine at the Icahn School of Medicine at Mount Sinai in New York.
Tell us about some of the scope of the work that your laboratory and your clinical activities encompass.
So I'm engaged in a fair amount of research related to uveitis, as well as some research related to macular degeneration. My areas of interest are immunology, the immune system, and inflammatory disorders. The work that I do in uveitis is largely clinical trials, where I chair a large multi-center clinical trials group, and we're studying various treatments related to the treatment of the more severe uveitis. The work that I do in macular degeneration really grew out of work that I've done for many years on AIDS and AIDS-related ocular complications.
Tell us about your current study on uveitis.
Well, currently we have two studies that are ongoing. The multi-center uveitis steroid treatment trial, which is a long-term randomized trial and follow-up study of comparing systemic therapy with oral corticosteroids and immunosuppression to local therapy with the fluocinolone acetonide implant. And the 2 and 4.5 year data have been published, and the 7-year data are being finalized and hopefully will be published in the not too distant future.
Was that data presented here at AAO?
So the data from the MUST trial show that systemic therapy, when used properly, can be given safely for a period of up to 4.5 years. Essentially, in the trial, there was no increased risk of systemic side effects versus a strictly local therapy, the fluocinolone acetonide implant. Those data are reassuring, as systemic therapy has been the backbone of treatment of the more severe uveitis. The implant, however, does have slightly better control of inflammation than does systemic therapy, and therefore really has a role in systemic therapy failures. However, because the implant has higher rates of ocular hypertension, glaucoma, and cataract, it probably is better as those who have failed systemic therapy than as primary therapy.
Steroids have been the mainstay of the treatment of uveitis for decades. What new immunomodulatory approaches are you looking at are interesting and potentially promising from your perspective?
Well, so there are multiple immunomodulatory drugs that we use. They're the conventional small molecules that are used in a variety of different diseases, both rheumatic diseases and transplant situations. And we use them similarly. But what's surprising, which I don't think any other discipline has found, is the ability to give them without any increased risk of systemic side effects. We really had a unique opportunity to evaluate this paradigm and demonstrated that they can be given safely.
Are the doses similar?
Yes.
And are you able to measure differential drug concentrations in the particular, in the uvea versus the circulation?
No, we don't. We use them in exactly the same fashion as you would use them in rheumatology or in transplant situations. Right. And we don't look at levels in the blood or in the eye, typically.
Let's talk more broadly about systemic inflammation and ocular disease.
Sure.
What are the important areas of research that you're currently pursuing and that you believe should be pursued by other researchers in this field?
So, what we found in our study of patients with AIDS was that they had a 4-fold increased age-adjusted prevalence of intermediate stage age-related macular degeneration, AMD, versus an HIV uninfected population. And that appears to be a consequence of what we see in these patients, which is an accelerated and accentuated aging. This occurs among patients who are treated with antiretroviral therapy, who are immunorestored, who do not have opportunistic infections. But what we see among those patients is that they still have shortened lifespan versus HIV uninfected patients, and they have an accumulation of age-related diseases, cardiovascular disease, diabetes, and so forth. We think that systemic inflammation plays an important role. We know that these patients, even when they're 40 years old, have an immune system that looks like a 75-year-old HIV uninfected person. And those immune changes we call immunosenescence. And what they're characterized by is an increase in terminally differentiated effector cells, a relative loss of naive cells, and immune activation and systemic inflammation. And we believe that that plays an important role in this accelerated and accentuated aging. We also believe that that plays a role in AMD. We know in HIV uninfected patients that if you have elevated biomarkers of systemic inflammation, your risk of AMD is increased. And we know that patients with AMD versus those without have evidence of activated monocytes circulating in the blood to a much greater degree. And we think that the reason we see the increased prevalence of AMD in patients with AIDS, all of whom are antiretroviral treated and immunorestored, is because of this immune activation and systemic inflammation.
What specific immune activation biomarkers are you referring to, and what are the most important ones if you were to prioritize?
This is where we're looking, and we will be looking at a variety of biomarkers related to systemic inflammation, coagulation, monocyte activation, and we'll also be looking at cellular activity related to immunosenescence. That's really where we're headed with this research, is to look at those areas in the patients with AIDS, and then, depending upon what we find, see if they're also operating in HIV uninfected patients.
Changing to patient recommendations, this is the section of the interview where we try to paraphrase your work and present to patients what the potential implications for them might be 5 or 10 years down the road of this particular line of work.
Well, so we know about the aging issues in patients who are HIV infected, antiretroviral treated, immunorestored. I think this is just one more thing to which they should pay attention. We don't know yet whether or not it will progress to late stage AMD, to neovascular AMD or geographic atrophy. We don't know yet the rate at which it will progress. So we don't have specific recommendations about prognosis, but we do believe that these patients should be seen and evaluated and managed as you would somebody who's HIV uninfected, but who is older, where you might worry about AMD.
Are you currently recruiting patients to your center? And if so, how would they get in touch with it? Is there a website, or are there recruitment offices?
So we're not recruiting patients anymore. The cohort from which this was drawn has finished. Follow-up is finished, and we're working with archived photographs and cryopreserved specimens to do this work.
Thank you so much for sharing these perspectives with us, and good luck with your work, and we'll continue to follow on.
Thank you.